So liver cirrhosis is a common endpoint of wide variety of the chronic liver disease, diffuse fibrosis and conversion of the normal liver architecture into structurally abnormal nodule. So here in this diagram, this structure here, this is liver and this is gallbladder. This hypoechoic region around the liver, this is ascites. If you closely look at the margin of this liver, you can see the margin is irregular, and the liver ecotexture, which should normally be homogeneous, here the ecotexture is coarse. If you look at the gallbladder wall is thickened. Normally, gallbladder wall should be less than 3 millimeter, but here this gallbladder wall thickness is increased. So these features are suggestive of liver cirrhosis. Common cause of the liver cirrhosis is alcohol consumption. Around 60 to 70% case of the liver cirrhosis is due to alcohol consumption, and alcoholic liver cirrhosis will lead to the formation of micronodules. Chronic viral hepatitis is another second leading cause of the liver cirrhosis. And in chronic viral hepatitis, you can see macronodules, biliary cirrhosis, Wilson's disease, and hemochromatosis. All of these can lead to liver cirrhosis. So what we actually see in liver cirrhosis in ultrasound, surface nodularity, it has high sensitivity and a high specificity. It has around 88% sensitivity and 82 to 95% is specific for the diagnosis of liver cirrhosis. Overall coarse and the heterogeneous ecotexture is also suggestive of liver cirrhosis. Here in this diagram, this structure is liver. Around this liver, you can see there is fluid collection. If you look at the margin of the liver, then you can see it has nodular surface. For the visualization of the margin of the liver, you should use linear high frequency probe. So in liver cirrhosis, you can see volume distribution. Volume distribution means there will be atrophy of the right liver lobe and there will be the hypertrophy of the caudate lobe. Here in this diagram, this structure is liver. If you look at the ecotexture of the liver, the ecotexture is coarse, it is not homogeneous, and the margin of the liver is irregular. And here this structure is caudate lobe. Caudate lobe is enlarged in this diagram in comparison to the right lobe. So caudate lobe hypertrophy is a feature of chronic liver disease. Other features, as I have already discussed, these are coarse ecotexture, nodular surface. Nodules can be regenerative or sometimes dysplastic nodules can be seen. And these dysplastic nodules should be differentiated from hepatocellular carcinoma. Sometimes in later stages of the chronic liver disease or liver cirrhosis, you can see portal hypertension, ascites, splenomegaly, and varices. Again, radiological features are hypertrophy of the caudate lobe. Usually there will be the hypertrophy of the caudate lobe as well as segment 2 and segment 3. And there will be concomitant atrophy of posterior segments of the right liver lobe. These are segment 6 and segment 7 of the right lobe. Here in this diagram, this entire structure is a liver. You can see the liver ecotexture is heterogeneous. These vessels are the hepatic veins. And this structure here, this is the caudate lobe. The caudate lobe has significantly enlarged in this patient. So, caudate lobe hypertrophy is a feature of liver cirrhosis. For the diagnosis of the liver cirrhosis, we can use hepatic CRL ratio. CRL means caudate lobe to right lobe ratio. For the measurement of the CRL ratio, we should take axial image immediately below the bifurcation of the main portal vein. We should be able to capture this type of the image showing left liver lobe, right liver lobe and caudate lobe along with portal vein and inferior vena cava. Once we obtain this image at the level just below the bifurcation of the main portal vein, and we should draw 3 different lines. One line should be drawn at the left lateral border of the caudate lobe. This is line 2 here. Another line is drawn at the right lateral side of the portal vein. Line 3 is drawn at the middle of the inferior vena cava and the portal vein. Then caudate lobe and the right lobe measurement should be taken. So we should take the measurement in between line 1 and line 2. This is the caudate lobe. On right side, lateral to line 1, this is right liver lobe. And we divide this distance with this distance. If this ratio is less than 0.6, then this is normal. However, in initial stage of the liver cirrhosis, there may not be caudate lobe hypertrophy. So if even if the CRL ratio is less than 0.6, and if there are other features of the chronic liver disease like surface irregularity, nodular outline, the coarse ecotexture, as well as if there is clinical suspicion as well as biochemical parameters are suggesting chronic liver disease, then even if the CRL ratio is less than 0.6, patient can have liver cirrhosis. The ratio between 0.6 to 0.65 is borderline. However, if the ratio is more than 0.65, then the patient is 96% is likely to have liver cirrhosis. And if it is more than 0.73, there is 99% is likelihood of having liver cirrhosis. In liver cirrhosis, due to increased resistance of the blood flow inside the liver, the velocity in the portal vein will be decreased. And in liver cirrhosis, it will be usually less than 15 centimeter per second. The diameter of the portal vein will be increased, usually more than 13 millimeter. The diameter is more than 13 millimeter, then this is highly specific for diagnosing portal hypertension. There will be the flow reversal. Normally, the blood should flow towards the liver, but in portal hypertension, due to increased resistance, the blood can actually reverse back from the liver. This type of the flow is called hepatofugal flow. And hepatofugal flow is usually seen in case of severe portal hypertension, as well as if there is portal venous thrombosis, then the flow reversal can be appreciated in portal venous Doppler. The tributaries of the portal vein, superior mesenteric vein and the splenic vein, will also be dilated. And if it is more than 10 millimeter, then we consider it to be enlarged superior mesenteric and the splenic vein. And enlargement of this vein is also a feature of portal hypertension. So measurements should be taken during deep inspiration, as the size can vary during respiration.